Hi everyone, we're still waiting for a few people to join, but while you're in this presentation, if you could keep your microphones muted, that would be great. And then we've got time for questions at the end, so you can unmute your microphones then or leave messages in the chat for any questions. Yeah, please let us know.
I think, yeah, we should get...
Yeah, people are joining, but we'll get started.
Hello, welcome and thank you for coming to the webinar. It's called Art Making and Neuro-disability at the RHN. My name is Briar and I'm the art technician here. I curate and facilitate the art groups and workshops that happen at the RHN, as well as one-to-one sessions, exhibitions, overall hospital projects that we do, and some external workshops as well. My main qualifications are in art and mental health, but my own art practice is all things ceramic based, so I kind of push that on all of our patients here. And I'm going to be doing this talk, obviously you've seen her already, with Kate, who is a much loved and valued occupational therapist.
Hiya, so my background is that I'm a rotational OT through the various services here. I'll explain a bit more about what the services are and what we provide in a minute. My experience is mainly in the acute settings. Before I worked here, I started 2 years ago and have worked in both the rehab side and the long-term care side. My role includes all of the kind of usual OT assessments, particularly with complex neurodisabilities. So thinking about things like tone, posture, awareness, cognition, function. I also look at long-term disability management and rehabilitation. So I work with Briar and I help with running weekly art groups, as well as doing one-to-one sessions with patients who have specific goals, whether that's functional or leisure.
You're going to be the button presser.
I can be the button presser.
Okay, so the introductions and aims of the webinar. So in this webinar, we're going to cover a few of these points, hopefully. The first one is we're going to introduce the RHN, our facilities, and how our services run. The second one, we're going to increase knowledge and understanding of occupational therapy and what role it plays within neurorehabilitation and general well-being. The third one, we're going to explore the value and purpose of occupational therapy art and showcase how we adapt creative processes to suit our patients with cognitive and or physical impairments. And then the final one is just to showcase and celebrate the neurodiverse art that is created in the art room at the RHN.
So to give you a brief introduction to the RHN and what we do here, we're an independent charity-run hospital with over 250 patients collectively across our hospital and long-term care units. So we have a population of adults with acquired brain injury. So you're thinking things like traumatic brain injury, strokes. And we generally don't accept degenerative conditions such as MS, but we do, to contradict ourselves, we do have a specialist Huntington unit, and we often have patients with MND admitted to our ventilator unit. We also have neurological patients with behaviours that challenge and a young adult unit. So our patients come with a wide variety of complex cognitive, physical, behavioural and communicative symptoms. All of our patients are very different, so we have to really tailor our specialist services to each of them. So like I said, our service is split up into two main domains. So that's our brain injury service. You're thinking about kind of the rehab side and the long-term care service. So the brain injury service is funded by NHS England for level 1 rehab. So the patients tend to stay for 10 weeks to 6 months, depending on their goals and how well they're progressing. And then the long-term care setting is funded by local authorities. So your CHCs, and residents tend to live here for a long time. So some of our residents have been here for over 30 years. Or some just come for a respite period. We have specialist services such as Compass, which is our computer service, who help us with all of our assistive technology. We have music therapy, psychology, hydrotherapy, which is currently shut due to COVID. I've said music therapy. We have a leisure service, and obviously we have art therapy or occupational art therapy. All of those services are funded by charity. So our patients' beds are funded by local authorities or NHS England, but the additional services that make us so specialist are all reliant on fundraising. So all of our patients have access to the art room via referrals from their treating therapist. The art rooms run one-to-one sessions, groups, leisure sessions, patient and family joint sessions, and MDT sessions, which are often a collaboration from the art team, OTs, physios, and psychology.
Okay, so it's a little bit confusing. So I'm going to try and explain what we do at the RHN. So this is the more art side of it. So as a starting point, we need to be clear that we are talking about, we're not talking about art therapy. I think it's useful to establish how the art service at the RHN provides a different service to art therapy, and it's a more so there are areas of similarities and areas of crossover, but the RHN specifically incorporates the art department into their OT team. So art therapy, as you all probably know, is more of a form of psychotherapy involving encouragement of free self-expression through art, which is used as remedial or diagnostic activity. And although our art room is often reported to have remedial outcomes and outcomes where our patients feel free to express themselves, we also focus on the more functional, interactive, and social side of art too. This is where occupational therapy is combined with art. Occupational therapy in general enables people to achieve health, well-being, and life satisfaction through their participation in occupation. Quite often, when you hear the word occupation, you think of a profession or job role, but the RHN also likes to think of hobbies and leisure as a vital occupation too. Art has been used in occupational therapy as a vital tool in helping patients to achieve their goals, in addition to being a source of enjoyment, a way to increase confidence and contribute to their overall recovery and rehabilitation. So from a therapist's perspective, this is very important, OTs strive to allow the experience of occupations to demonstrate recognition of simultaneous goal achievement. That is, in the sessions, we might set out with a goal in art for improving upper limb strength, but in addition, the patient may also gain confidence and a sense of purpose in what they are doing, and therefore the occupation widens the goal achievement and becomes much more meaningful.
So art can link into OT in many ways, including looking at assessment. So we often use art materials and mediums to provide sensory stimulus for our prolonged disorder of consciousness patients. We can also use functional sessions to assess cognition, so looking at things like apraxia, processing, sequencing, problem solving, looking at carryover between sessions. Then we can look at physical ability, so things like patient's grasp, functional movement, and not just range of movement, and coordination difficulties. We can use sessions for our interventions, so we can use it as part of their treatment program to make exercises more interesting. We can do upper limb exercises, cognitive goals, looking at errorless learning, but just incorporate it into an art setting and with meaningful tasks. We can then link this back to what is meaningful to the patient, including their previous roles, occupations, and responsibilities. So the sessions don't need to be in the format of traditional art. We've had lots of patients who, for instance, have been tradesmen. They've never done art in their lives. They're not really interested in what they perceive to be art, but they've used the art room to build their own toolbox using bits of wood, tools, screws, things that they're kind of used to, rather than looking at painting in clay and things like that. And it's really meaningful to them to do something that they were doing prior to their brain injury. It can be a really holistic intervention to work on physical and cognitive skills, as well as their goals post-injury, whilst connecting to their previous role and identity.
It's also important to say that the art room is a space that's not focused on disability and it's not clinical at all in its appearance. So completing the functional sessions out of a clinical setting helps reduce boredom, it breaks up the day, it increases motivation, it aids concentration by reducing external stimuli, and it provides a social element to patients' therapy. Also within a neurological setting such as the RHN, the main focus will often tend to be on the physical and cognitive goals, which are more easily measured given the complexity of the client group. However, we have observed the impact that art treatment has on psychological well-being, although that obviously is quite a bit harder to measure.
So we run weekly sensory art groups here. We run them for both our long-term patients and for our rehab patients. So at the RHN, we use the art room for diagnosis as well as for annual reassessment for patients in prolonged disorders of consciousness. So prolonged, I don't know how much you already know about PDOC patients, which is the abbreviation, but a prolonged disorder of consciousness is an umbrella term which encompasses coma, vegetative state, and minimally conscious state, which are all conditions which a patient has severely limited and impaired levels of awareness and wakefulness. Therapists, in particular OT, are largely involved in the diagnosis of PDOC. So we complete all of the assessments alongside other AHPs, which are then sent to the neuroconsultant to confirm the diagnosis. And it's really important as part of the RCP guidelines that all patients in prolonged disorders of consciousness are diagnosed, because it looks at their long-term management in terms of their health and their treatment escalation plans, and just generally kind of to inform family and allow them to know where their relative is at and what their potential for progression and things is. So the RCP guidelines state that to correctly complete PDOC assessment, patients' behaviour must be observed at rest, and then they're provided with auditory, tactile, visual and olfactory stimuli in a controlled manner, e.g. providing one stimuli at a time and then given appropriate time to respond in the case of delayed processing speeds. Following diagnosis of PDOC, formal clinical re-evaluation should occur annually until the patient dies or emerges from PDOC. So it's really important for us to continue assessing patients. So that's why it's a really useful tool both in our long-term care setting and the rehab setting. So the assessments we use when assessing awareness are the ones we use in the art room are our own RHN form, which you can see on the left, and the WIM, which is the Wessex Head Injury Matrix, which you can see on the right. So when assessing for awareness, we're looking for spontaneous, reflexive and purposeful responses to stimuli provided. And dependent on what those responses are, depends on kind of where they sit within their diagnosis of a prolonged disorder of consciousness. To diagnose a patient with PDOC, patients must receive two types of standardised assessment, of which there are three, which is the Coma Recovery Scale Revised, the WIM, which I've already mentioned, and a SMART assessment. And the choice of those two assessments is decided based on the patient and clinically reasoned by expert PDOC assessors, which is what we all are here. So the Coma Recovery Scale, which is also called the CRSR, and the SMART are two standardised to use within an informal art session. So they're still used within our formal therapy sessions up on the wards, and they're still used for diagnosis here, but they're not used within the art room. They don't kind of fit our ethos of what the art room is supposed to be for, and don't really fit that setting. So in the sensory art one-to-ones or groups, we use the RHN form on the left and the WIM on the right. So the RHN form can't be used for diagnosis because it's not an approved standardised assessment by the RCP, but we are able to use it to formulate our documentation of responses, and it's also a really nice qualitative evidence of what responses people had, which we can then compare from previous assessments, especially with our patients who have been here for 30 years. we can see what changes they've had over the years. And it's a nice kind of comparison to the quantitative data you get from the other assessments.
Sensory traits. So, like Kate has explained, we run our sensory group in the art room for several reasons. These sensory trays aim to stimulate a sense from each of the patients. So this would be visual, auditory, tactile, or olfactory, which is smell. And often the patients that attend these groups are in PDOC or just emerging. And we use these sessions to observe how each patient reacts and enjoys the stimulus or not that we provide. And obviously, as Kate has said, we use these forms to assess that. The art room creates a tray that has a theme to create an overall experience and a sensory journey for our patients. We believe that if a sensory session is going to take place in the art room, then it has to be creative and filled with plenty of colour and as exciting as possible. So on the slide, we have a picture of a recent favourite, which was our cinema sensory tray. As you can see, the tray has the cinema classics, a plasticine hot dog that you can squish in your hand, tactile velvet material to mimic that of a vintage cinema seat, a cinema ticket that you can track eye gaze with and gain attention from the patient. And we also had popcorn and strong smelling sauces like mustard to create the overall smell of a cinema experience. So this brings me on to our next slide, which highlights some of the mediums and techniques that are used within our art service. It's not an extensive list because that actually is endless. We're lucky enough to be supported and solely funded by charitable donations, which is absolutely lovely. And it means that our patients aren't limited in what they can create and they can, access anything. Some examples of the most widely used approaches are pottery. It's popular due to its physical and sensory benefits, and also the fact that it's my favourite medium to work with. Free painting, it's familiar to us all and therefore it's accessible for everyone. It provides immediate results and with no obvious failure. And paper mache, again, popular for the sensory element it provides. And it's a combination of sculpture and decoupage. Like I said, we're so lucky that we have a large range of resources that we can tailor the sessions to the individual to maximise their interest and motivation. And we offer our people a chance and a choice at doing something that they wouldn't have done before. If the individual is unable to tell us themselves, we often refer to their family and friends to see what they would like to do or what they have done in the past. And it means that we can tailor and personalise each session to make it a nice experience for them. We also run functional art groups, and they are also assessed and staffed by therapists and therapy assistants. These run like a typical art workshop. So for example, our groups can span from a pinch pot making session, clay self-portraits, which are usually rather hilarious and quite fun to do, half-face drawings. I should have put a picture on, but it's like half a picture of a famous painting that you complete the next side. We've done graffiti and spray painting before, still life etchings, and anything that I think will be fun and accessible for the patients that have been referred. The aims of the group, they're vast, but they tend to be to create a fun and social environment, to engage our patients in fun and creative functional tasks, to provide an activity that will help improve and adjust the patient to any physical or cognitive deficits that they might have, and to see how long the patients can actually engage in a session for. So our art groups also involve patients from the same or different wards and are great for social interaction and meeting new people. It's a chance to learn possibly a new skill or perhaps continue with a past hobby. and we have lots of different adaptive equipment that make the activities accessible for all levels of abilities, which hopefully makes the art room accessible to the entire hospital and anyone that wants to come in. And I think Kit's going to talk about some of that equipment.
So in the art room, we have a variety of ways we can adapt the space and the equipment we use to make the sessions more inclusive for patients with a wide variety of impairments. So if we're thinking about the sensory element, so some of our patients can be photosensitive, so we're able to adjust the lighting. We're also able to make the room as quiet or as lively as required, so we can keep the room for an exclusive use for a patient, so we can have minimum distractions and they can concentrate, or we can do several one-to-one sessions at a time with music playing to make it a more social environment, as well as the groups. And we try to tailor so that we have functional patients in a group and sensory patients in a separate group, kind of as we've said, so that the PDOC patients can have a really quiet environment so that they can have those stimuli provided one at a time rather than hearing lots of distractions in the background. If we're looking at the physical adaptations, so all of the doors and spaces are wide enough so that they're wheelchair accessible. We have lots of different types of wheelchairs here, lots of custom wheelchairs which are potentially wider and longer than your kind of average wheelchairs that you might have. All of our tables and sinks are height adjustable. And then we also have a wide range of equipment, including some of the photos that you can see on the slide. So we use a lot of the tubing you can see at the top. This is really cheap and really easy to get, but it's great because you can use it for paintbrushes, pens, anything to kind of help with grip. We can use it for art itself. It's very adaptable and really, really cheap to use. The glove on the top right, I don't know if you can kind of tell what that does, but it essentially negates the need for a grip. And patients who are able to, if they have kind of a one-sided weakness, they can use their other hand to put it on themselves and use the loopholes to readjust the angling of the pen or paintbrush that they're holding. It's good for patients who have got kind of a distal weakness, but approximately quite well. But you can use it in combination with other pieces of equipment as well for patients who might have weakness throughout their limb. And then, sorry, let me get my page there. And then in the middle, you can see we've got what's called a mobile arm support. This is used to de-weight a patient's arm so that they can have ease through anti-gravity movement. So a lot of our patients have some movement, but it's just not strong enough to be able to move against gravity. We've got a patient who will kind of come on to in a bit, and she's been using this, and it's been really helpful for her. Each piece of equipment is prescribed by the treating OT, so that OTs will be very involved with the sessions. It kind of works quite nicely between OT and Briar and Christina, who also works in the art room, and we kind of come together to think of ideas of kind of mediums we can use and equipment we can use to tailor each session to the patient. So the activity we select is completely tailored to the patient's needs, interests and abilities. We have to adapt the tasks accordingly, including the materials. For instance, silk and kind of water paints are much easier to use than acrylic paints, which are heavier and more difficult to move. And lots of our patients have issues with communication, so we might use visual imagery if they have receptive or expressive aphasia. They might rely on assistive technology to communicate, as you can see above. We have patients who use eye gaze, as well as using kind of tablets or touch style communications, or really simple low-tech AAC, so pointing at an alphabet chart. And some of our patients might need written instructions, visual instructions, or visual examples of what we're doing in the session.
So as well as all the groups, we also offer one-to-one art sessions, sessions that are purely for leisure, which is lovely too. Whether it's a chance to learn a new skill or perhaps continue with a past hobby, there's many reasons why someone is referred to us by the OT team. It also means that we can find projects that have personal value to the individual. And it could be a present for a family member or just something for them to remember their time here and the progress that they've made. So like I said before, the art room really does evade the likes of the clinical space. As you can see, it's quite chaotic and colourful. There's no large or ugly equipment that gives reminders of it being a hospital environment. And it's a space purely focused on art with colour and sensory stimulus throughout. And the therapeutic benefits of this really mustn't be underestimated. We even get some patients that just like to come into the art room and look around. It has been reported to have a relaxed feel, and it is away from the wards, so that it's kind of been described as a hidden therapy. Art provides, as you know from if you've been listening, many functional benefits, but we also see the improvement in our patients' social comfort when they enter the room. And I always waffle on about how it's a space for creative freedom, time out, and often making mess, which I have to clean up. We also love running patient-family sessions and can see the joy and reconnection that it brings to our families who have their loved ones at the hospital. The support from the family members is often very encouraging for our patients, and it's something that can bring a sense of relief and joy in really quite difficult times. On to lovely Diana. We thought it would be really useful to show you a video of a session that includes not only adaptive equipment, but also the art mediums that we would provide for a patient. Diana has kindly volunteered herself to show how she uses the AAC eye gaze communication, the ergo armrest that we talked about, and Kate will go into more detail about this.
So this is Diana. Diana's a patient on my ward on the long-term care setting. So she had a posterior stroke and was admitted here to the nursing home in October 2021. So she's only been with us for less than 6 months. She's an American citizen, and so she was ineligible for rehabilitation under the NHS. So she kind of skipped the rehab side of her journey. So she came straight to the nursing home after her acute hospital admission. When Diana came to us, she had a dense weakness throughout her body, but she was able to demonstrate movement of her head through nodding and shaking. So we would call her partially locked in. So she wasn't able to communicate through anything other than her head nod and shake. When she was at the acute setting, they set her up with what's called an e-tran board, which is a low-tech version of eye gaze, and it really relies on the other person being skilled to be able to use it. So she would use her eyes to look at a letter through a plastic board, and it would rely on the person holding that board to tell which letter she is looking at, which is very time-consuming. It's very difficult for her, it's difficult for the user, and generally just not very patient-friendly. But that was her means of communication when she came to us. Assessments that she had showed that her cognition remained largely intact following the stroke. But she was often quite distressed as she would become easily uncomfortable. She's had lots of issues with being unable to reposition herself. So she gets uncomfortable quite quickly, and then without lots of distraction, it's something that she ruminates on, so she can get quite upset. Since she's been here, we've been able to set up Diana with eye gaze communication, so she's able to communicate herself. You'll see in the video how she uses that in a minute, which means that she can also use a call bell on her head support, which I don't know if you can see on the right, the blue switch. So she can use her head to turn and press the switch. And what she does, which is great, is she already types out the message for what she wants before she calls the bell, so that when the nursing staff get to her, they know exactly what she wants. Most of the time it's to be repositioned or reshuffled, just to offload her pressure. So she started to demonstrate increased movements in her right hand. So when she came here, she had a slight flicker in her fingers, and she's now able to, with a bit of support, use a tissue to wipe her mouth. So she's really progressed her upper limb movement. She demonstrated an interest in art. She hadn't done any art before, but she's generally up for doing anything. But she's quite a creative lady. She likes dancing, singing. She's very social. She previously used to cater for weddings as well as being a carer. So we thought it would be good to refer her to art, partly for social interaction, partly for a distraction from the discomfort. The more activities she has, the less distressed she becomes. We wanted her to have more meaningful activities, but we also thought it would be a really good adjunct to give her some kind of functional side of her upper limb therapy along with her OT program, which she's covering with the OTA. So she continues to have ongoing weakness. So she requires support to de-weight her upper limb. You'll see in the video that I'm actually supporting her elbow. We've used the mobile arm support, and we do generally use this with her. But as I said, lots of equipment has limitations. And one of those limitations of the mobile arm support is that it reduces your range of movement. And due to where she has weakness and what we were doing with her, it was better for her to have more freedom of movement. So I'm just de-weighting her arm for her. So if you're in a setting where you can't afford fancy equipment, you can do those kind of techniques yourself, but obviously it's less independent for the patient themselves. She uses lightweight paints. She uses kind of water paints or silk rather than heavy acrylics. We've tried acrylics with her, but it just provided too much resistance. So we found that she'd get stuck on one area of whatever she was painting. It's also quite a sticky paint, so she would find that her paintbrush would get stuck to the paper and she wasn't strong enough to move it. She uses her AAC within sessions to choose songs, to tell us what she'd like to do next. And she also likes to tell us about her life and what she was doing before her injury. She really enjoys her sessions, and her upper limb movement has really improved since she started them with us. So I hope I can make this video work.
turning out to be a very lovely scarf. It's actually really long, so she's doing frame by frame in each session, and it's really cool. So finally, I would like to summarise the many ways in which art is such a vital tool for so many areas in people's lives. I strongly believe that whether you consider yourself arty or not, there are so many ways in which art can infiltrate one's life in such a positive, freeing and productive way. Just to name a few, art can help when you are faced with reforming an identity. Whether this is adjusting to a new disability, art can help you regain confidence by pushing you out of your comfort zone, and it allows for self-exploration as well. Art can help our patients develop a new interest, and sometimes we see them participating in art and pottery classes once they've left the RHN, which is always fun. Art can also, as you've seen, help improve our patients regain physical functions. And finally, art has no obvious failures. So my rule is you simply can't do anything wrong in the art room, and it should be a positive experience for everyone.
So in conclusion, we believe that art's a vital tool within the occupational therapy services. We can see what a meaningful tool it is and a vast range of benefits that can be gained from engaging in something without realising. It can be accessed by a wide range of people, from low level looking at sensory reintegration to someone like Diana regaining skills that could lead to regaining lucrative ability and sense of self. We feel passionately that we all, regardless of age and circumstance, should attempt to explore and learn new skills which help to develop and grow. And art can be an additional significant route to rehabilitation through the art sessions at the RHN. We provide the environment, encouragement and expertise to allow individuals to self-express, build confidence and enjoy a rewarding experience, as well as achieving their OT goals.